Hey guys, welcome back. I'm Akanksha Jain, your clinical psychology educator, and this video is brought to you by Psychological. So, in the last session, we completed our module 2, and today we will be starting with our module 3. I hope you did attempt the mock tests for the previous sessions and you were able to attempt those, and you did a quick revision as well. But before starting today's session, we will be doing a quick revision of whatever we covered in the last session. So in the last session, we talked about anxiety disorders, obsessive compulsive related disorders, and stress and trauma related disorders. Let's start with the first thing that we discussed, which was anxiety versus fear. We said that fear is related to the present danger, while anxiety is a future possibility. We also talked about how in DSM-4, OCD was a part of anxiety disorders, but in DSM-5 TR, it's a different chapter in itself. Then we moved on to different kinds of anxiety disorders. We discussed GAD, panic disorder, agoraphobia, specific phobia, social anxiety disorder, separation anxiety disorder, and selective mutism. If I have to go and talk about one point from each, I would say that we need to remember that generalized anxiety disorder, the worry should be out of proportion and for more than 6 months. And we remember 3 or more out of the 6 criteria for adults and 1 for children. It was REST MI to remember it, right? We also talked about Dugas's intolerance of uncertainty scale. Then we moved on to panic disorder. In panic disorder, we talked about how panic attacks does not equal to panic disorder. Okay, for it to be a panic disorder, there should be anticipatory anxiety and persistent concern for at least 1 month, or some kind of behavioral change for at least 1 month. Okay, and then we moved on to agoraphobia. We said that in this situation, the anxiety should be about the fact that the escape might be difficult or help might not be available. And we talked about 5 particular situations. Okay, then we talked about specific phobia. There were some types. It is an intense but irrational fear of specific objects or specific situations like animal, natural environment type, blood injection injury. We talked about vasovagal response when it comes to blood injection injury type, right? And then situational type, other types. Then we talked about social anxiety, separation anxiety, and selective mutism. Okay. Then we moved on to OCRD, obsessive compulsive related disorders. We first talked about OCD. It is a self-perpetuating cycle. It starts with obsession, moves on to anxiety, then compulsion, then temporary relief, and then it is how is it imposed? Negatively reinforced. Okay, we talked about how obsessions are different from compulsions. Obsessions are recurrent, persistent, intrusive, unwanted thoughts or urges or images in your mind. And what is compulsion? Compulsions are behaviors or mental acts, repetitive behaviors or repetitive mental acts that you perform to reduce that anxiety. Then we moved on to some themes or subtypes of OCD: contamination, harm or checking, symmetry or ordering, forbidden thoughts, and things like that. We discussed about BDD and hoarding disorder, body dysmorphic disorder and hoarding disorder. We said that in body dysmorphic, it is about the perceived defects in physical appearance, while hoarding disorder, it's about persistent difficulty in discarding objects. Okay. And then we talked about trichotillomania and excoriation disorder. Trichotillomania was about hair pulling disorder, while excoriation was about skin picking. And these both are body focused repetitive behaviors, BFRBs. They often co occur with OCD and anxiety. Then we finally moved on to stress and trauma related disorders. We started with PTSD and we said that 4 symptom cluster is the most important part here. We said it's intrusion, avoidance, negative cognition or mood, and hyperarousal. These symptoms should last at least more than 1 month. And we also talked about an assessment scale, which was PCL-5. We said that when it is about children, the symptoms, display themselves in different ways. When we are talking about children, we mean less than 6 years old. It is usually through reenactment of the trauma, through play, through art, through drawings, and things like that. And we also said, what if these symptoms were less than 1 month, but more than 3 days? We said when the symptoms are less than 3 months, we can't call it PTSD. But if it is more than 3 days and less than 1 month, we call it acute stress disorder. Then we moved on to complex PTSD, which is only in ICD-11. We said that obviously the 4 symptom cluster of PTSD is there, but what is added? Self-organizational difficulties. Difficulties in self-organization, affective dysregulation, negative self-concept, and difficulties in relationships. That is what we added here. We also talked about adjustment disorder, where there are emotional or behavioral response to an identifiable stressor. It's not something out of proportion. Okay, and then we talked about some other disorders in very brief, like RAD, reactive attachment disorder, where we said that RAD and DSED, disinhibited social engagement disorder, these occurs in severe cases of childhood abuse. In the first, the child becomes very withdrawn and has difficulty forming relationships, while in the other, DSED, they become way too attached, like even to strangers. Okay, so which is not normal. We also talked about prolonged grief disorder. We said at least more than 12 months in adults the grief should last, and for more than 6 months in children. Then we talked about some treatments like TFCBT, ERP, SSRIs, SNRIs, and what is the first line treatment for what. And then we finally also talked about some important assessment scales like GAD, HAMA for GAD, PDSS for panic disorder, YBOPS for OCD, and PCL5 for your PTSD, and LSAS for social anxiety disorder. So that was all what we discussed in our last session. Today we will be starting our module 3, psychopathology and lifespan issues. So let's talk about what we will be covering today, like a roadmap of today's session. Okay, so today we will be covering dissociative disorders. We'll discuss disorders like DID, dissociative amnesia, depersonalization, derealization disorder, and how to differentiate between DID from schizophrenia, things like that. Then we'll also talk about somatic symptom disorders, which is one of the most confusing areas in psychopathology, because students often mix up somatic symptom disorder, illness anxiety disorder, conversion disorder, fictitious disorder, malingering, things like that. Then we'll also talk about feeding and eating disorders, where we'll talk about feeding disorders, pica, rumination, and aphorid, while we'll also talk about some eating disorders like anorexia nervosa, bulimia nervosa, binge eating disorders. And then we'll also talk about substance use and addictive disorders, including DSM-5 severity criteria, alcohol, opioids, cannabis, gambling disorder, and also some stages of change model. Okay, this is something that we will be discussing today in details. We'll also do a very quick, brief review of sleep-wake disorders and sexual dysfunctions, and some important assessment scales. One thing that you need to remember here is usually in CUET, PG, and UGC net, they rarely ask one question from every disorder. Instead, what they tend to do is they focus on higher differentiation, like how you differentiate this from that. Okay, so throughout the lecture, pay special attention whenever I compare two disorders, okay, because those comparisons are much more likely to appear in exams than standalone questions. And obviously, if you want detailed notes that are concise, colorful, packed with mnemonics and examples that will help you to remember everything comparatively easily, you can find the link in the description below. Okay, so now that we are headed, let's begin with our first major topic, which is dissociative disorders. Okay, but to understand dissociative disorders, we need to answer one very basic question. What is dissociation? Okay, so let me ask you some questions. Okay, have you ever, like if you drive, of course, have you ever driven home and suddenly realized that you don't remember the whole journey, okay, when you reached home, right? Like you were driving in an autopilot mode, okay? Or has it ever happened with you? I mean, I'm pretty sure it has, okay? You're in a class and the class is going on, the teacher is speaking and speaking and speaking, but your mind is somewhere else, like you're disconnected, you're daydreaming, you don't even know what happened in the class, okay? Or if you've ever gotten into an accident, it's like you have watched yourself getting into that accident from outside your body. It is happening in front of you, or you don't even remember the whole accident, okay, but you were there, it happened with you. So what is actually happening? Okay, what is happening is basically that we are getting disconnected from the reality, from our surroundings, from whatever was happening around us, okay. That disconnection, that happening in autopilot mode, is basically what we call dissociation, okay, basically what we call dissociation. Now in a normal setting, when we dissociate, we usually snap out of it. So whenever we dissociate, whenever we are in autopilot mode, we usually snap out, okay. When you reach home, you realize, oh, I reached home, you snapped out of it, okay. You got lost in the class, okay, but then you say, oh, I'm in the class, and you try to refocus in the class, okay. Or whenever you get into accident, you finally reach, or if you're hurt, you snap back, right? You snap back to the reality. But what would happen if you're not able to snap back? You're stuck there for a longer period of time. It's intense, and it is often happening with you. That is the situation where this turns into a disorder. Okay, it is not only affecting one part of you, but it is affecting your actions, your behavior. You're disconnected with what you're doing, you're disconnected with yourself, with your surroundings, your thoughts, even your physical sensations, everything. Your mind is disconnected with, disconnected with everything that is around you. Why is this happening? Why is your body behaving like that? Why is your mind behaving like that? Basically, what happens here is your mind is trying to protect you from some kind of trauma, some kind of stress, some kind of overwhelming emotion. Your mind is using dissociation as a defense to protect you from that. So, dissociation as a defense, right? So, this imagine that you're not able to remember your own name or important aspects of your life, or you feel like your body does not even belong to you. That is the level of disruption we are talking about in dissociation, which distinguishes it from a normal experience to a pathological one. Now let's look into the DSM-5 TR definition. Okay, dissociation refers to a disruption or discontinuity in the normal integration of consciousness, memory, identity, emotion, perception, body representation, motor control, and behavior. Now, obviously, the definition sounds very technical, so let's try to simplify it. Think of your mind as a well organized machine. Okay, so normally your thoughts, your memories, your emotions, your identity, your awareness, all of these work together smoothly. But what happens in dissociation is this teamwork of the machine temporarily breaks down. These mental functions becomes disconnected to one another. Now, again, why does it happen? So, dissociation develops as a protective response to the overwhelming stress or the trauma. So, when an experience becomes extremely painful or threatening to your normal processing, the mind may disconnect certain memories, certain emotions, or perceptions as a coping mechanism. Now, initially, this can be very adaptive. It helps the person to survive an extremely distressing event. However, when dissociation becomes very persistent or occurs even in safer situations, okay, it starts interfering with your daily life and may develop into a dissociative disorder. So the key point here to remember is dissociation is not the same as forgetfulness or daydreaming. It is much more significant, much more deeper. Okay, it is causing some kind of clinically significant clinically significant impairment. Okay, so see, we said mind temporarily disconnects, protects you from overwhelming stress, may be maladaptive. As we said, initially it might be adaptive, but on a longer term, it's maladaptive. We also talked about some important terms like memory, identity, perception, consciousness. So my memory is like forgetting important events, identity is like, feeling like different identities exist. Perception is like feeling detached from yourself or your surroundings. Consciousness could be disruption in your awareness. So important point here is that dissociation is not the same as repression or ordinary forgetfulness. Regression is a different concept. Repression is a different concept. If we compare it with repression, repression is unconscious blocking of unacceptable thoughts. That's not dissociation. Dissociation is disruption in the integration of psychological function. So your mind, your hand is working, your mind is working, your you're also working, so your legs are working, but these all functions are disconnected with each other. And this is also different from normal forgetfulness because there are what is normal forgetfulness? It's normal memory lapses. There is no significant impairment with it. Okay. So remember, dissociation is disconnection. Mind disconnected. Okay. Not forgetfulness. Okay. Not forgetfulness. Okay. So now that we understand what dissociation is, let's look at different disorders that fall under this category. Okay. So, if I have to start this, think of it as something you don't have to memorize because each disorder answers a different question. The first disorder is DID, dissociative identity disorder. The primary disturbance is identity. The primary disturbance here is identity. Okay. Next is dissociative amnesia. The main problem here is memory. Here the main problem is memory. The next one is depersonalization, derealization disorder. Depersonalization, derealization disorder. Okay, here the main disturbance is perception and awareness of self or the surroundings. So let's just say perception and awareness for now. Okay, we'll obviously discuss this in detail. So perception and awareness. Perception and awareness. Then we have said OSDD and UDD. OSDD is other specified dissociative disorders and UDD is unspecified dissociative disorders. These are diagnoses used when a person has clinically significant dissociative symptoms but does not fully meet the criteria for one of these specific disorders. Okay. Now, do you notice the spectrum that I have given here at the bottom of the slides? Okay. Dissociative disorders lie in a continuum. What do I mean by that? Let's see. On one end, you can see we have DPDR, depersonalization, derealization disorder. Okay, and on the other end, we have DID. Okay, dissociative identity disorder. Okay, so if I talk about DPDR, DPDR is just one major symptom, feeling detached with oneself or from the environment. Okay, it's like I'm watching myself bahar se. the environment is very distorted or blurred. If when I get into an accident, suppose it's like I'm seeing the accident happening to me from the outside. It's like an out of the body experience. Or if you've seen, in a lot of movies, Karhona comes to my mind a lot of times, with that Saif Ali Khan shot. The environment gets distorted and you are the only one walking. So like those. So the question that we say here is you're detached. Okay. It says that I feel unreal. Okay, I feel unreal. Moving further, we have dissociative amnesia. It represents a greater disruption because memory is significantly affected. It's like you're forgetting your personal information. Okay, there is loss of memory, but the identity of the person is intact. So what we're saying here is, I can't remember. This is how you remember these disorders differences. Here, DVDR, I think unreal. In amnesia, I can't remember. Let's move forward. With dissociative identity disorder, the most complex form. It involves disturbances in identity, memory, and often other psychological functions as well. So, what here happens is your continuity with your own identity is lost. Okay, like I'm not one me. I am not one me. This is what it says. Okay, we will discuss this disorders in a little more detail, and you can see here a little note about ICD-11. It also includes partial DID, which is partial dissociative identity disorder, and trance and possession disorder. We'll come back to possession trance later because it is commonly confused with psychotic disorder, especially in Indian context. Okay. So what you mainly have to remember is DID is about identity, amnesia is about memory, DPDR is about perception and awareness. Okay. Let's begin with the most recognized disorder, which is dissociative identity disorder. Many people know it from the movies, but the real clinical disorder is quite different from how it is portrayed in the popular media. So what does the term come into your mind when I say DID? One of the most famous term is split personality. Split personality. Is it correct? Yes. It is a popular term, yes, but what we use clinically is distinct identity states because it is more accurate. Distinct identity states. Okay. So the idea is characterized with two or more distinct identity states that recurrently take control of an individual's behavior. These identities, or what patients often describe it as parts of me, differ in the way of thinking, behaving, remembering, or even interacting with the world. One important thing to understand about this is that it's not having multiple personalities in a very dramatic sense. Okay, instead it reflects a disruption in your normal integration of your identity. You're usually developing after a severe or a chronic trauma, particularly during childhood. Okay, so what do we mean by the term identity states? Okay, think of identity as the answer of the question, who am I? Okay, in most situations people would say identity is integrated and stable. What happens in the idea is this integration is disrupted. Different identities have different names, different ages, different voices, different memories, different emotional responses. So the first feature that becomes here is identity switching. Different identity states execute their control at different times. Sometimes these switches are very obvious to you, but often, most of the cases, they are very subtle in nature. They even go unnoticed by a lot of people. To use a very simple example, imagine a patient suddenly finds clothes in their wardrobe that they don't remember purchasing, or discovering messages on their phone that they don't even recall that they sent. Okay, no, this is not normal forgetting. Okay, this is different than that. The second feature is memory gaps. Patients frequently report that they're unable to recall important personal information. Okay, as I already said, it could be, they don't remember buying things or some conversation they had. Okay, then there is depersonalization or derealization. We will be discussing this in the depersonalization derealization disorder itself, but not every patient with DID will experience depersonalization, but many do. Okay, many individuals experience feeling detached from themselves or from their surroundings. And then the fourth important point here is distress and impairment. There should be some kind of distress, there should be some kind of impairment when it comes to social settings, occupational settings, or even your personal functioning. Now, the key point here is DID involves presence of two or more distinct identity states. That's the key point. Okay. Okay, one thing that students often confuse is DID is equals to multiple personality disorder. Okay, DID is equals to multiple personality disorder. This is correct, but this term was used till DSM-4 only. Okay, since the DSM-5, the correct diagnostic term is dissociative identity disorder, emphasizing that the problem is with the fragmentation of the identity instead, or rather than the existence of completely separate personalities. Okay. Okay. Now let's move on to understanding the ID in terms of its etiology, its assessment. Okay. Um, what do you think causes DID? We have already discussed the DSM-5 features. Okay. In this previous slide, which we said as clinical picture. Okay. So, what do you think causes DID? Trauma, overwhelming stress. That is correct, but trauma alone is not enough. Many people experience trauma. Okay, but they never develop DID. DID is believed to be the result of the interaction between some severe childhood trauma or and developmental vulnerability and dissociation as a coping mechanism. Okay, this is explained through trauma model. Um, okay, trauma model. What does trauma model say? This model says that DID usually develops following a severe, chronic, repetitive childhood trauma, which is particularly physical or emotional or sexual abuse or severe neglect. Now, what happens is the child's psyche is still developing. Okay, and what the mind does is the mind copes by separating traumatic memories and experiences into different identity states. So, it is important to remember that not everyone who's experiencing trauma will develop DID. Okay, now when we come to the assessment, it is primarily based on detailed clinical interview. Okay, detailed clinical interview in history, because there is no blood test or brain scan which can confirm the ID. Okay, so obviously again, why this clinical interview helps, because you can understand different identity states, the fragmentation of the identity, and one of the screening tools that helps a lot is dissociative experience scale 2 DES2. Okay, it helps identify dissociative symptoms, but obviously it does not diagnose DID by itself. It's just a screening tool. We'll also focus on the treatment part. Okay, so the first line of treatment is phase-oriented therapy. Phase-oriented therapy, psychotherapy. Now, what it does is, rather than trying to eliminate the identities, it focuses on three goals. The first one is establishing safety and stabilization. The therapist first helps the patient to understand, to feel safe, and to learn emotional regulation. That is the phase one. Second is trauma processing. When the patient is stable enough, only after that we explore the traumatic memories. We explore the traumatic memory gradually after the patient is stabilized. And the phase 3 is integration and rehabilitation. Now, the goal is improved functioning and cooperation between the identity states, not the removal of it, but cooperation between the identity states. Then for the integration, so complete integration may occur in some individuals, but therapy is individualized. The aim is better functioning, not forcing the personalities to disappear. Very important. And one more important point here is medication does not treat DID directly. There is no particular medication for DID. Okay. However, medications may be prescribed to the patient if they also have conditions like depression, anxiety, or PTSD. Now, one thing that you need to know is that in movies often portray DID as violent or dangerous. In reality, individuals with DID are far more likely to have experienced severe trauma than to be violent toward others. So this is one of the major misconception which contributes to the stigma. Okay. Moving on to dissociative amnesia. Okay, so we have explored the disturbances in the identity. Let's move on to the disorder where the main disturbance is memory. Okay, here the identity is usually intact. It is the autobiographical memory that is disrupted. Okay, the term is here autobiographical memory. So what do we mean by the term autobiographical memory? Autobiographical memory means memories about your own life, your own experiences, your personal events, important life information. It's not memories like, capital of India or, your 2 into 2 is 4 or any kind of vocabulary. Okay, those are generally preserved here. Okay. It is characterized by an inability to recall important autobiographical information, see, personal information, usually which are of traumatic nature or very stressful in nature, okay? And the memory loss is too extensive to be explained as, you just normally forgot, okay? An important point here is that memory loss that happens here is psychological in origin. It is not due to any kind of neurological conditions like dementia or head injury or substance use even. Okay, it is psychological in um nature, psychological forgetting, psychological. Okay, let's look into some different types of dissociative amnesia and understand that. So let's start with localized amnesia. This is the most common type. That is something you need to know. It is the most common type, often asked in exams. So this is the most common type. Here the person cannot remember events during specific period, like could be like hours after the traumatic event happened. Why is it localized? To understand this with an example, it could be like you can't remember the whole day when the accident happened. Okay, so that would be a localized amnesia. What is selective amnesia then? Selective amnesia means you forget only parts of an event. Okay, while the other details you remember perfectly. Like you remember the whole accident, but you forget the part where the actual impact was. So, like, suppose there was a huge landslide. Okay, so you remember the whole landslide, but you forget the part where you got hit by it. Okay, so that's selective amnesia. Then generalized amnesia, which is much rarer. Okay, which is rare. Okay, the person loses a memory for their entire life history, their entire identity. Okay, they can't remember who they are or their life story, the people around them, things like that. Continuous amnesia, it involves forgetting new events as they occur from the particular point. So, if the accident happened today, whatever happens from today, they cannot remember that. Okay. And then we have systematized amnesia. It refers to memory loss related to a specific category. It could be like, memories associated to a particular person or a particular place. Okay, suppose there was some kind of trauma related to a person who got into an accident, let's say their son. Okay, so they forget that particular family member. That is systematized amnesia. Then we have dissociative fugue. So, this is a very important concept, first of all. So, please remember this. In dissociative fugue, what happens is a person may suddenly travel away from home or work and may even become confused about who they are and even temporarily assume a new identity. Think of it as amnesia plus unexpected traveling. Okay. Now, one thing that most importantly you need to remember here is that it is not a separate disorder anymore. In DSM-5, it is a specifier of dissociative amnesia. Okay. And another important thing to remember is the memory loss cannot be explained by any medical or neurological condition. Okay. Also, one more thing, there is a difference between organic amnesia and dissociative amnesia, as we already said about the neurological cause. One more thing that you need to remember about that is in organic amnesia, there could be multiple memory systems that is affected, but in dissociative amnesia, it's only your personal memory or autobiographical memory that is mainly affected. Okay, let's move on to depersonalization and derealization disorder. So now we have discussed the disorders related to identity and memory. So here the main disturbance is perception, specifically of how a person experiences themselves and the world around them. So, have you ever been exhausted or stressed that everything around you feels very unreal? Okay, that kind of brief experience can happen to anyone, to a very healthy individual as well. It only becomes a disorder when this experience is persistent, it reoccurs, okay, and it is causing you distress and obviously impairing your daily functioning. So let's start with the first one, which is depersonalization. I feel unreal. What I mean is that your own self, you yourself feels unreal. You don't feel like yourself. Okay. It is a feeling of being detached with oneself. It is often described by the patients as they're watching themselves from outside their body, or as they're living a dream or observing themselves in a movie. Okay, things like that. Then the second term is derealization. The world feels unreal. Your surroundings don't feel real. Okay, the external world isn't real. They feel like your surroundings is foggy, it's blurry, it's distant, it's like a dream. It's artificial. Okay, so the answer here is who is feeling unreal. If the answer is me, it's depersonalization. If it's the environment, The answer is derealization. Now, here's the most important point. The patient says that I know this feeling isn't true, but I still can't stop feeling it. Normally, what happens in psychosis is that the person believes that their experience is true. Here, the person's reality testing remains intact. What do I mean by that is that they know that these feelings are subjective, that they are not actually happening, that they don't actually believe that they have left their own body and the world has literally become artificial or something like that. They know that these feelings are not real, okay, but they still can't stop feeling it. In psychosis, they believe that it's real. So their reality testing remains intact. This is what differentiates depersonalization, derealization from psychotic disorders. That is why we have mentioned here the ID versus schizophrenia, because it is the most confused disorder, especially due to very inaccurate portrayals of it in movies, and also one of the most important comparisons because a lot of questions come from here. Okay, so in dissociative identity disorder, the problem is fragmentation of identity. The person is experiencing two or more identity states along with memory gaps. While in schizophrenia, the problem is psychosis. There is a loss of contact with reality. As I said, whatever they feel, they believe it's real. Here we know it's not real, but we're still feeling it. Okay. One thing that you need to know is that hallucinations may occur in both disorder, but they're different in nature. Like in schizophrenia, the hallucinations are usually the part of the psychosis. They're experienced as something coming from the external world, from something around you. But in DID, patients may describe hearing internal voices of different identity states, of different parts of themselves. Okay. These experiences need to be carefully evaluated in clinical settings and should not be automatically labeled as schizophrenia. Okay. Why I say is about this voices thing is, if the patient says I hear another part of me talking, that's DID. But if the patient reports like someone is talking to me, or my laptop is sending me messages, that's schizophrenia. There is a difference between psychotic hallucinations or delusions where the reality testing is impaired. Okay. Significant autobiographical memory gaps are common in DID due to dissociation. In schizophrenia, memory problems may occur, but they are not characteristic dissociative amnesia seen in DID. Another major difference, reality testing, as you already said, DID usually has better reality testing, whereas schizophrenia is characterized by impaired reality testing because of the psychotic symptoms. Okay. So, what basically we remember is that reality testing is one of the easiest ways to differentiate these disorders when it comes to examination questions. DID generally preserves, schizophrenia is often impaired. And finally, when we talk about treatment, of course, DID is primarily treated with psychotherapy, while schizophrenia requires antipsychotic medications. Okay. One thing that we need to importantly remember here is that ICD-11 recognizes trance and possession disorder, okay, within dissociative disorders. Now, in these cases, the person appears to be controlled by another identity or spirit, but the symptoms are involuntary, causes distress, impairment, and it cannot be explained by the culturally accepted religious or spiritual practices. It is very important because in many cultures, especially in India, we have accepted religious possession rituals. These are not diagnosed as a mental disorder when they occur as a culturally sanctioned context. The key word here is culture. If it is culturally accepted, it's not a mental disorder. Involuntary possession experiences which is causing distress or impairment may be diagnosed as trance and possession disorder according to ICD-11. Okay, now let's move on to somatic symptom and related disorders. So first of all, let's have an overview of it. If someone is having a chest pain, but every medical investigation comes back out normal, does that automatically mean they're pretending? No, right? In psychology, we never jump to that conclusion. The symptoms and distress can be genuine, even when there is no clear medical explanation. Okay. So these disorders are often confused because the symptoms are physical, but the primary problem lies in the person's thoughts, in their emotions and behaviors, and are related to those symptoms. A common misconception is that these patients are pretending or that it's all in their head. Neither of those statements are correct. Okay, the symptoms and the distress both are real. What makes it a disorder, what makes these disorders in fact different is that the person's excessive concern, their anxiety or behavioral response to these symptoms. Okay, the focus is on physical symptoms or health concerns, but the psychological response is excessive compared to what would be typically expected. Okay, so let's just see what the disorders are first. First, we have somatic symptom disorder. There are physical symptoms with excessive concern. Illness anxiety disorder, fear of illness despite minimal symptoms. Okay, conversion disorder, which is now actually known as functional neurological symptom disorder. That is the main name. Okay, conversion disorder was a previous name. And then we also have capricious disorder, symptoms intentionally produced to adopt the sick role. Okay, let's see these in detail. So to understand somatic disorder, we'll understand somatic and illness in a comparison way, which makes it easier, and also that is how the questions appear. Okay, so the question here that we are asking is, what is the patient primarily worried about? Okay, if the patient is worried about the symptoms, it's somatic symptom disorder. But if the patient is worried about having a serious illness, what do we think about is illness anxiety disorder. Okay, let's understand the core focus first. In somatic symptom disorder, the patient is distressing about somatic symptoms that interfere with their daily life. They may have a chronic pain or fatigue or some kind of stomach complaint or constant headaches or some other bodily symptoms. Their attention is centered on these symptoms and how they're making their life difficult. Okay, while in illness anxiety disorder, the focus shifts completely. The patient is preoccupied with the possibility of having a serious disease, even when the physical symptoms are either absent altogether or are very, very minimal in nature. So the fear is not the symptom, it is that what does that symptom represent? Okay, so in SSD, physical symptoms are usually a lot. There are multiple symptoms, they're distressing, they're recurring. While in IAD, the symptoms are very minimal, or sometimes completely absent. So let's say a SST patient, somatic symptom disorder patient would say, this pain is making my life miserable. Okay, but what would an illness anxiety disorder person say? I'm having this pain and I think I have cancer. This pain means cancer. One was focused on the pain, the other is focused on the disease they might have. Okay, so that is how it works. Okay, so that was what the core focus, the somatic symptom, the primary concern talks about. Okay, now let's talk about health anxiety. Again, both disorders are involving anxiety, but the health anxiety is usually secondary in SSD to the physical symptoms. Okay, the symptoms come first, while in the illness anxiety, as the name suggests itself, that is the central feature. That is the central feature of it. Okay, they even minor things that happen in the body, they interpret it as something very serious disorder. Okay, let's look into medical utilization. Patients with somatic symptom also make frequent visits to doctors because they generally want their symptoms to go away, the relief from the symptoms. While the person in this anxiety disorder, they repeatedly seek reassurance. Okay, they'll seek reassurance that they don't have any kind of illness. Okay, in fact, there are interestingly some patients who do the opposite. They avoid hospitals or even investigations because they are terrified of the fact that there will be a diagnosis and which will confirm their worst fear of having some kind of worst disorder. Okay, then we have insight. Patients with illness anxiety disorders are often strongly convinced that they have some kind of illness. Okay, so the insight is usually poor. Okay, while when we talk about SSD, okay, symptoms are real, so insight fluctuate. Okay, then we talk about the duration. Both should be more than 6 months, and the impact of functioning. The first has significant impact, the second should also have a significant impact. The terms that you need to remember is focus is on the symptom, the focus is on the illness. Okay, let's move on to conversion disorder. Now this disorder is now known as functional neurological symptom disorder. Okay, let's remember that do not get confused if you see either of the names. Okay, they are the same thing. Why is this disorder unique? It is unique because the patient presents with neurological symptoms. The main neurological symptoms. Okay, like it could be a paralysis in the limb, or they're not able to see, they're not able to speak, they've lost their voice. When I say they're not able to speak, it's they've legit lost their voice, or they're having some kind of tremor, there's some kind of abnormal movement, even seizures for that matter. So there are symptoms that are neurological in nature, but these symptoms are not fully explained by any recognized neurological disease or any other medical condition. Okay, so at the first glance, the symptoms look very similar to some kind of disorder. But when you have a careful neurological examination and proper investigations, you'll see that the findings are incompatible with any known neurological disease. So remember the words incompatible. not medically unexplained. Why? That is the DSM update. Earlier, the classification emphasized that the symptoms were medically unexplained. But DSM-5 said, where this name came, that the focus is of clinical evidence showing inconsistency with recognized neurological disorders. So, the question that arises here is, are these patients pretending? Are they just, they want something out of it? No. They are not intentionally produced or faked. These patients generally are experiencing these symptoms. Okay, they are experiencing some kind of blindness, tremor, paralysis, non-epileptic seizures, speech disturbances, something. Okay. So what is actually happening? Okay. When we say that it is intentionally produced or fake, you're talking about fictitious disorder, malingering. We'll discuss that. Okay. Historically, this disorder was linked to the psychological conflict converting into physical symptoms, conversion, which is where the name came. Okay. Today, we know that the psychological stress can be associated with the disorder, but a psychological stressor is not actually required for the diagnosis. Okay. Some patients report a clear stressful event before the symptom onset, while some patients have no particular stress. Okay, let's see. These symptoms look very dramatic, often lead them to emergency departments. But what is one important clinical point is, before diagnosing conversion disorder, clinicians must first rule out that if there is any genuine neurological illness. Okay, and remember that conversion disorder is neurological symptoms, not a disorder, without compatible neurological disease, and the symptoms are not intentionally produced. That is what it all talks about. There are assessments and there are treatments, which you can obviously see that it is mostly psychoeducation, therapy, and all. Okay. Let's move on to factitious disorder and how it is different from malingering. Okay. Now, here we're asking the question, are the symptoms fake? Okay. And the answer is yes for both. They both are intentionally produced in both conditions. So, how do you differentiate? We ask another question. What is the person's motivation? Okay, let's start with factitious disorder. Okay, what is the motivation? In fictitious disorder, the person deliberately produces or exaggerates their symptoms because they want to adopt the sick role, okay, to be in the patient's role. They want to be seen as a patient. They want attention, they want care, they want sympathy, they want the emotional benefits out of it. But they're not looking for any kind of external reward. They're not looking for any kind of external reward. Okay, that is important. Like someone may intentionally, they have a wound, okay, they got hurt, they got a cut, they'll intentionally contaminate it, or they'll bring in false medical reports, or even do something extremely, injecting themselves just to remain hospitalized or just to get care. Okay, but it is different from malingering, because malingering is also intentionally produced, but the motivation is completely different. Here it's about the external incentive. It could be financial, it could be avoiding some kind of work or some kind of exam. It could be to obtain drugs. It could be to avoid some kind of responsibility or some kind of insurance benefits, things like that. There is an external reward to it. Okay, so while they are both looking similar when we look at from the surface, the motivation is where the difference lies. That is where we differentiate this. Okay, so the factitious disorder is asking, can I become a patient? Malingering is asking, what can I gain out of it? Okay, you can see the behavioral pattern, multiple hospitals, doctor shopping. While malingering is situational, is there any kind of reward present with it? Okay, as I already explained some of the examples, right? So now that we are done with somatic symptom disorders as well, let's move on to another important sector of disorders, that is feeding and eating disorders. One thing that you need to notice is that DSM-5 divides these conditions into feeding disorders and eating disorders. They sound similar, they're not the same. Okay, feeding disorders, they usually begin in infancy or childhood. Begin in infancy or the childhood. Okay, some can be seen in adults and in adults, but usually this is the case. While when we talk about eating disorders, okay, this is something that you will be very familiar with. That is, and this is more about weight gains and what you eat. So let's talk about some of the feeding disorders first. Okay. this is very rarely asked this as standalone questions. Okay, this is something that you normally see as options or distractors. Okay, let's begin. So we'll do it in a very short way. Okay, let's start with pika. Okay, so pika is a persistent eating of something that is not food and not nutritive substances. Okay, it would be something that, like, how you've heard, like, this child is just, always eats soil or chalk or anything, soap, hair, paper, ice. Okay, now remember that it should be developmentally inappropriate. This should be developmentally inappropriate. Remember that, because, for example, a 1 year putting objects in their mouths is normal. Okay, and that is not a pica disorder. So it, and also something that is not culturally accepted. Okay, some things are very culturally accepted as well. Okay, and so that is something that you need to differentiate. And also remember that pica is formally associated with ID, autism, and also sometimes pregnancy. Okay, particularly when there are nutritional deficiencies like iron. Okay, so that is when we can see this. So it is non-food substances. That is what you need to remember. Now, rumination disorder. What does rumination disorder mean is, here the person regurgitates their food after eating. That is what you mean. They will bring back the food, they'll re-chew it, re-swallow it, or even spit it out. Okay, that is what is happening here. They are not vomiting. Remember that. Okay, that is usually associated with some kind of nausea or some kind of GIT problems. Okay, here the regurgitation is effortless. There's no effort into it, and it is repetitive in nature, and it cannot be explained by any kind of disorder or any kind of problem. Okay, that is what happens in rumination disorder. It is effort. Remember the terms: effortless and repetitive. Effortless and repetitive. Then we have AFRID. AFRID is avoidant slash restrictive food intake disorder. Avoidant slash restrictive food intake disorder. What is happening here is, the person restricts their food intake, but not because they want to lose any kind of weight, or because they think they're overweight. Instead, they avoid eating food because they dislike some kind of textures or smells or colors or even the taste. Some develop the disorder after something happened to them, like a choking episode, or because in general they have very less interest in eating itself, so they're restricting their eating habits, but it is not to lose weight or anything like that. Okay, it is often confused with eating disorder, so we'll discuss that as well. Again, remember, not commonly asked but are used, so just have an idea of what these disorders are. Now let's move on to some important disorders like anorexia nervosa, one of the eating disorders. Okay, there are three important essential criteria. Okay, the first is persistent restriction of energy intake. Okay, due to significantly low body weight. The second is intense fear of gaining weight or becoming fat, and the third is disturbance in a way that the person experiences that differently, how they look, their body weight, their shape. Okay, so while they have this constantly fear of gaining weight, they will count every calorie, they'll skip meals, they'll exercise excessively, they'll develop rigid food rituals. Okay, despite becoming severely underweight, they often continue to believe that they need to lose more weight. Now, also notice some subtypes here. Okay, there are two types written here: the restricting type, the binge eating or purging type. The restricting type achieves weight loss primarily through dieting, fasting, excessive exercising, while the binge eating, purging type, what they do is they'll have binge eating episodes where they'll eat a lot, but they'll purge. They'll have purging behaviors, like they'll self-induce vomits or they'll use laxatives. Okay, remember that this is a subtype of anorexia nervosa. This is not bulimia nervosa. Okay, now let's discuss some medical complications that happen with it. So, prolonged starvation, they can develop bradycardia. Okay, what is bradycardia? It means slow heart rate. There's also a risk of electrolyte imbalance, especially with purging behaviors. And these electrolyte imbalances are so significant that they even become life-threatening because they risk cardiac disorders. Okay, then another important is osteoporosis. They reduce the bone density. due to malnutrition and hormonal changes, and then another is hypothermia. It is because they have so little body fat, they have difficulty maintaining their body temperature. Anorexia nervosa also in severe cases has the highest mortality rate among psychiatric disorders due to both medical complications and also an increased rate of suicide. Okay. You don't need to know the statistics, but something that is very important is one of the highest mortality rates in psychiatric disorders. Now, treatment is always very important and it is multidisciplinary. There is nutritional rehabilitation, there is CBTE, which is enhanced cognitive behavioral therapy, one of the most effective ones in this case. Then for adolescents, we also have family-based therapy. It is known as Model C approach. Okay, Mod C approach. Remember this? Okay, it has a strong evidence and it is actually considered as one of the first-line treatments. Okay, and also one thing that you need to remember is it has the lowest DMI among the disorders. Okay, now one more thing, as I mentioned in Alfred. Okay, Alfred and Ian are confused a lot. Okay, remember, why is the person restricting food? Is it because they are afraid of gaining fat or gaining weight, or they don't like the texture, or some other kind of problem that they are facing? That is how you differentiate. Okay, let's move on to bulimia nervosa and binge eating disorders. Okay, in both cases, they look identical in the first glance because both have recurrent binging episodes. Okay, now the question is, what happens after you binge? If the person tries to compensate for that binging episode, that is bulimia nervosa. Okay, there is compensation here. That is the important part. Okay, compensatory behavior. Okay, while if there is no compensatory behavior, without compensatory behavior, that is a binge eating disorder. Okay, so a binge episodes usually means eating unusually large amount of food within a short period of time. Like, it's like you don't have the control over what you're eating. Okay, it's just simply cannot stop eating. But after that bitch comes shame, guilt, fear of gaining weight. So to get rid of those calories, they engage in compensatory behaviors like, again, self-induced vomiting, misuse of laxatives, diuretics, fasting, excessive exercising. Okay, so that is what they are doing. See, binge episodes forging, yes, bulimia. Binge episode forging, no, binge eating disorder. So in binge eating disorders, they do not regularly engage in compensatory behaviors. And both disorders require binge eating at least once a week for 3 months. Once a week for 3 months. And let's talk about body weight as well, because students often get confused here. Patients with bulimia nervosa usually have a normal body weight or maybe slightly overweight, because the compensatory behaviors partially offset the calorie intake. But the patients with binge eating disorders, on the other hand, are more likely to be overweight or obese, since there is no compensatory behavior. Notice I said more likely. Being overweight is common in BAD. It's not a diagnostic criterion. It's not necessary to be diagnosed. Okay? Again, when we talk about their treatment, CBTE is one of the best treatments out there. Then there's also nutritional counseling, lifestyle interventions, and things like that. Okay, now let's see a short comparison here to understand how you differentiate between these three. Okay? Take a screenshot of it, because very important. Remember, is there a concern about eating weight? Is there a significantly low BMI? If yes, anorexia nervosa. If no, are there recurrent binge eating episodes? Yes, compensatory behavior is there. Yes, bulimia nervosa. No, binge eating disorder. Take care. This is something that you need to remember, how you differentiate between these three. Okay, because that is how the questions normally come. Okay, now let's look into the assessment and treatment review. Although I've already given you a small idea of how it works, you need to remember that first line often differs for each disorder. Okay, the first tool on the slide that we have mentioned is EDEQ. It is Eating Disorder Examination Questionnaire. It's a self-report questionnaire assessing your eating disorder symptoms like restraint, eating concern, shape concern, weight concern. Okay, then we have SCOFF. It is again a screening questionnaire. Also something that we have seen in exams. S is, do you make yourself sick? The term is sick here. Do you make yourself sick because of feeling uncomfortably full? Then do you worry about the loss of control? The loss of control, or how much you eat. Then, have you recently lost more than 1 stone, which is about 6.5 kilograms in 3 months? So 1 stone. Then F is, do you believe you're fat? Do you believe you're fat? Or when others say that you're too thin? And would you say the food dominates your life? So these are the kind of questions that you will say. Generally, if there are 2 or more yes responses, we need more further assessments, as it is a screening tool only. Then we check your BMI, body mass index, because it is important for anorexia nervosa. Moving on to treatment, we already said CBTE is one of the standard and the go-to way of treatment. It works on changing dysfunctional beliefs about food, weight, shape, eating behaviors, things like that. And we have nutritional rehabilitation, which is especially critical in anorexia nervosa because, you have to effectively address that distorted thinking. The patient often needs medical stabilization as well. So there is restoration of adequate nutrition. Then family therapy, because, it is considered for first-line treatments for adolescents and anorexia nervosa, especially because it actively involves parents in helping restoring the healthy eating patterns. Then there are some medications that you need to look into. For bulimia nervosa, we have fluoxetine. It is the only SSRI especially approved by FDA for BN. It is used alongside psychotherapy. There is no first-line medication for AN, and then there is one for specific drug lisdexamfetamine. Okay, this is again only currently FDA approved medication for moderate to severe binge eating disorders. Okay, but remember, it is only combined with some psychological treatment or lifestyle interventions. Okay, with this, we are done with your feeding and eating disorders as well. Now, before we enter substance use and addictive disorders, let me tell you how you can attempt the mock test for this particular session. So, as usual, you'll find the link in the description. You click on that link. When that link opens, you'll see the area where you can enter your name. Then you enter your registered email address and then you enter the test code. The test code for this particular session is YS655. YS655. Also, remember while you're entering your email ID as well as the test code, remember to not leave any spaces in the middle. Okay, attempt the mock test, check what you have understood, what you have not understood. Okay, go and revise that. It will help you prepare for these examinations. Fine, now let's move on to substance use and addictive disorders. Let's have a quick overview as usual. Before we discuss alcohol, opioids, cannabis, these things, let's understand how the DSM organizes this entire chapter. Okay, so what you can see in the left, okay, alcohol, opioids, cannabis, gambling. Okay, what is interesting here is gambling is not a substance. Now, gambling disorder is the only behavioral addiction officially included in the substance related and addictive disorders in DSM-5. Very important question. Okay. Now look at the flow, which is on the right side. The first stage is simply substance use. Using the substance itself does not automatically mean the person has a mental disorder. Then there is intoxication. It refers to temporary effects that occurs while the substance is active in your body. Okay, the key word is temporary. Once the substance is metabolized, it leaves your body. Intoxication is also resolved. Then we have withdrawal. Withdrawal occurs when someone has been using this substance regularly, reduces or stops using it, and the body reacts to the absence of that substance. Okay, again, the symptoms will depend on the substance that you were using. Like, alcohol can cause tremors, sweating, anxiety, sometimes delirium. Opioid withdrawal is usually body aches, runny nose, watery eyes, yawning, gastrointestinal problems. So they are different. The withdrawal shows different symptoms. Then we finally come to substance use disorder or SUD. That is the psychiatric diagnosis. Unlike just intoxication or withdrawal, which are temporary in their nature, this disorder refers to a persistent pattern of problematic substance use, which leads to some kind of significant impairment or some kind of significant distress. Now, it is important that the students understand these terms because they are used interchangeably but are treated as separate clinical entities. Okay. Now, why am I describing intoxication or withdrawal or underlying substance use disorder? Okay, the distinction is very frequently asked in entrance exams. Okay. So, what we need to remember is DSM-5 separates intoxication, withdrawal, and substance use disorder. Now, let's first understand the effects of intoxication, withdrawal, and finally how DSM-5 diagnoses the substance use disorder. Okay. So, DSM-5 lists 11 diagnostic criteria, which is very overwhelming. Now, the good news is you don't need to memorize them as isolated ones. If you understand the logic behind them, they become much easier to remember. So, when do we actually diagnose a substance use disorder? According to DSM-5, a diagnosis requires at least 2 criteria occurring with a 12-month period. True criteria occurring with a 12-month period, and it should again cause clinically significant impairment of distress. Okay. The first one is loss of control. The person is repeatedly using more of the substance than intended or continues for longer than they planned to use it. Okay. The second is craving. This refers to a strong urge to or desire to use that substance. Okay. It was actually added in DSM-5. Okay, it was added in DSM-5. The third one is tolerance. So over time, the same amount of substance not produce the same kind of effect anymore. So the person keeps on increasing that amount to achieve the same kind of desired effect. Okay. Then we have withdrawal. Okay. When the substance is stopped or it is reduced, there are characteristic symptoms, as I earlier mentioned, for alcohol, for opioid use. So what happens is these withdrawal symptoms develop, or the person uses the substance again to simply avoid these withdrawal symptoms. Now notice some of the next criteria. There is time spent, there is important activities you have given up, okay, using, things like that. Okay, now the person spends a great deal of time obtaining that, using that, or recovering from that substance. That is what time spent is. Okay, then we are saying important activities giving up. So they begin giving up important social opportunities, occupational opportunities, or recreational activities that they used to be involved in, because what is becoming the priority? The substance. Then in social interpersonal problems comes, because obviously when you are continuously using, there will be responsibilities that are being neglected, right? So that will create some kind of social problems, some kind of interpersonal problems. As the next mentions, there are role obligations that are neglected, like they are missing their work, they perform poorly in college, they are not fulfilling their family obligations. Then we have use in hazardous situations. So there is so many common cases of driving while drinking, or smoking cigarettes near petrol stations. Okay, so that the point is that they're not able to avoid it, for even in this situation where it could be hazardous in their nature. Okay, despite getting even medical advices from the doctor as well. So things like that. Continued use defied physical or psychological problems. You go to doctor is saying you'll destroy your lungs or things like that. So despite physical or psychological problems that they're facing, maybe to breathe or things like that, they keep on using it. Reduce or fail to quit. Unsuccessful attempts to cut down. They do generally want to stop, but they are repeatedly failing when it comes to that. Now, great deal of time and money spent using it's again the same as time spent. Okay. So think of them as impaired control, social impairment, risky use, pharmacological changes, things like that. If you remember these four domains, which are impaired control, social impairment, risky use, and pharmacological changes like tolerance and withdrawal, you'll remember it very easily. Now, what DSM-5 classifies this as is, according to severity, is according to the number of criteria that are met. So if there are 2 or 3 criteria only met, it is mild substance use disorder. If 4 or 5 criteria are met, it's moderate. If more than 6 is met, it is severe in nature. Important to remember. Remember this point. Okay. Now let's move on to alcohol versus opioids versus cannabis. Instead of trying to memorize how each substance separately, notice that how what I have done is that slides follow. The slide has some similar pattern. Clinical picture, withdrawal, and one important point. Okay, so let's start with alcohol. Now, what happens during an alcohol intoxication is we'll commonly see disinhibition. What it means is that the person will become more talkative, more impulsive, more uninhibited in social situations. As the intoxication will increase, their coordination will worsen. There will be slurred speech. They won't be able to talk properly. Okay, there will be ataxia. What is ataxia? It means difficulty maintaining your balance or coordinated movements. Then let's talk about alcohol withdrawal. Withdrawal is usually when does it begin? Usually within hours, okay, after they have reduced or they've stopped heavy alcohol use. So they'll develop tremors, they'll have sweating, nausea, vomiting, anxiety, they're not able to sleep. However, the complication everyone should remember is delirium tremens. Yes, here it is. Delirium tremens, often abbreviated as DTs. The full form is delirium tremens. What is delirium tremens? Delirium tremens. Now, this is an extreme or a severe form of alcohol withdrawal which is characterized by confusion, agitation, hallucinations. There is also instability and even seizures. So, it becomes a medical emergency at this point. Okay, this is important. Remember this. Okay, so remember that alcohol withdrawal is the only withdrawal that can be life threatening among all these three. All these three, this is the only one that can be life threatening. Okay, now let's move on to opioids. Now, during an opioid intoxication, patients usually experience euphoria or sedation. Okay, the classical physical sign that you'll mention is that there is constricted pupils known as meiosis. Meiosis. Constricted pupils known as meiosis. Okay. Now, what happens when there is a withdrawal in this case? Okay, it is often described as the worst flu that you can imagine. Okay, the worst kind of sick you can get. There is muscle ache, extreme muscle ache, bone pain, anxiety, you're restless. Okay, there is your running nose. Okay, there are your watery eyes, you're yawning unstoppably. There is stomach cramps, there is diarrhea, there is goosebumps in your whole body. Okay, now all these symptoms are very uncomfortable, but one thing that you need to remember is it is not life threatening. It is rarely life threatening. Okay, people will feel like they're dying, but they're not actually. Okay, now let's look into cannabis. Now, what happens in cannabis intoxication is that the person experiences relaxation, euphoria, obviously, and even something's altered perception. Um, and another feature that it's mentioned here is impaired short-term memory, which is why people sometimes have difficulty remembering their recent conversations or even concentrating in their normal tasks. So what happened when we withdraw from it? Okay, it is much more milder than alcohol or even opioids. Okay, it is normally just irritation, anxiety, sleep disturbances. You feel less hungry, things like that. It and again, like unlike alcohol withdrawal, it is just self-limiting, and rarely have any kind of serious medical complication. So that is why I have given here a comparison which you can see, like only alcohol is dangerous to the point that it is life threatening. Okay, when it comes to these are for withdrawals, tremors are there in this alcohol. There is the pupils, the constructed pupils are in opioids, and delirium tremens is in alcohol again. Okay. Remember, only alcohol withdrawal can be life threatening. Very important point. Now let's move on to the only behavioral addiction disorder when it comes to substance use disorder. So there is no substance being consumed, obviously. Then why is it here? Gambling disorder activates many of the same brain reward pathways that is involved in substance addiction. Okay, that is why it is here. It is particularly, the dopamine reward system that is activated in substance use. That is the same thing that is activated here as well. So this leads to the biggest example of the slide is that only behavioral addiction recognized in DSM-5 TI. Okay, we are going to do it in a very short way. So again, it is a persistent or recurrent pattern of problematic gambling behavior. 4 or more criteria should be met, to for a 12 month period. What are those criteria? You can see here in the clinical features: preoccupation with gambling, increasing the amount of money. The second feature important is the tolerance part. Okay. Then there is repeated unsuccessful attempts to stop. There is restlessness, irritability when they're trying to stop. One important feature is that they particularly like chasing losses. Chasing losses. Imagine someone loses 10,000 rupees. Instead of stopping, they immediately gamble again because they believe that they'll recover that money they just lost. So there is the cycle to win back the previous loss, which is called chasing losses. Okay, one of the hallmark features of gambling disorder. Then we also have lying to family members or friends, and again affecting your work life, financial stability, relationships, and things like that. If we discuss the treatment, it's CBT. There is also motivational enhancement to increase the readiness to change. Then there is there is alcohol anonymous and narcotics anonymous. There is also gambling anonymous. Okay, and again there is no particular specific medication for gambling disorder, and again medications can be for co-working conditions, but not particularly for the gambling disorders. Okay, now let's discuss one of the most important models related to substance use. Okay, known as stages of change. Okay, it is also known as trans theoretical model. Trans theoretical model. Who gave this model? This model was given by Francesca and Di Clemente. Francesca and Di Clemente. Remember that. Sorry, this is Di Clemente. Yeah. Okay, so this model helps you understand where a person is in the process of changing their behavior. Okay, very important when it comes to substance use and addiction behaviors. Okay, so let's see the stages. It is usually in a a cycle, as we can see. Anyways, yeah. So let's start with the first stage. The pre-contemplation. What is happening here is that the person is not even thinking about changing. Okay, they may even deny that there is some kind of problem, or they simply have no intention to change their behavior. So you can see the example here. I don't think I have a drinking problem. Okay, let's move on to contemplation. Now the person believes that they have some kind of problem. They might have some kind of problem, but they're still ambivalent about it, and they're thinking about the pros and cons of changing. Okay, so they are in that maybe stage. Okay, so maybe I need to change, maybe I don't. Okay, things like that. So here you can say maybe I should cut down, right? Then is the preparation stage. Here, the decision has been made that okay, I do have a problem and now I need to change that. The person is planning to change. They may even start setting goals or make arrangements that will help them change. So, like here, you can say, okay, I will quit next Monday. So, that is preparation. They're not started yet, but they're prepping for it. Then comes action. Okay, here is actually where the behavioral change begins. Okay, they have finally decided that they have started working on that decision. I'm not drinking today. Okay, the person is actively trying to modify their behavior. They might attend therapies, they avoid triggers, things like that. Then is the maintenance. Okay, maintenance is like now the person has successfully maintained their new behavior for a period of time and is working on not to fall into the same cycle again. Okay, so like it's been 3 months, I'm staying on track. There is some kind of achievement that you can see. They're working on maintaining that change. Then comes relapse. It is not again important that it happens, but it might happen. What is happening is you think that the person has fallen into that habit again. Now, many people think that relapse is failing of the treatment. No. The most important thing that you need to remember is that relapse is the part of the change. It's not a failure. A person may return to their old patterns of behavior, but that does not mean that they start from zero. Instead, that they learn from that relapse episode and they re-enter the cycle with a greater understanding, with a greater insight of it. That is why this model is circular instead of straight. Change isn't a one-time event. It is a process. People may move forward, backward. It's not a set it's in stone. They have to go through several stages before achieving any kind of long-term recovery. It is not only widely used with substance use, but also smoking cessation, weight management, exercising, other health behavioral changes as well. What you need to remember is pre-contemplation, contemplation, preparation, action, maintenance, and relapse. Remember that. Okay, also known as trans-theoretical model given by Prochaska and Depersonalisation. Now, very, very brief, what we're going to cover is sleep-wake disorders and some sexual disorders. Okay, so we're going to start with insomnia disorder. One of the most common sleep disorder. What is happening is difficulty falling asleep or difficulty staying asleep, or you wake up too early and can't fall back to sleep. Okay, so the sleep problems occur despite having an adequate amount of opportunity to sleep. And it is causing some kind of significant daytime distress or impairment. Okay, many people have occasional bad night sleep before an exam or interview. That does not mean they have insomnia. Okay, they have to be persistent, they have to be clinically significant. Then we have narcolepsy. And with this, narcolepsy. Okay, narcolepsy, extreme daytime sleepiness. Okay, like there is this overwhelming urge to sleep despite having adequate amount of sleep at the night. You still have this excessive need to sleep in the daytime. Okay, and what makes narcolepsy so unique is cataplexy. Okay, what is cataplexy is there is sudden loss of muscle tone in the body, which is usually triggered by strong emotions like it could be happiness, it could be surprise, it could be even anger. Okay, and the person remains consciousness, but they'll suddenly just collapse. They'll face this weakness in their face or in their jaws or even knees. Okay, and whenever you see excessive daytime sleepiness with catalepsy, you have to think narcolepsy. Okay, then we have obstructive sleep apnea. Very simple. What happens is there is obstruction in the upper airway during the sleep. The airway repeatedly collapses, your breathing temporarily stops, your oxygen levels fall. Okay, and the person will briefly wake up to just open the airway without even realizing that this happens. Okay, you'll see this person will normally have loud snoring, pauses of breath during their sleep, and they'll have morning headaches or daytime sleepiness because their sleep was not proper. Remember, this daytime sleepiness is because of a problem in the sleep, because they didn't get adequate sleep at night. This is not narcolepsy. Then we have parasomnias. Parasomnias are usually very unusual behaviors that occurs during sleep. Have you seen Chennai Express, Deepika Padukone, right? That is a very funny example of parasomnia. Okay, parasomnia has sleepwalking, night terrors, okay, things like that. So as it is already mentioned, sleepwalking, night terror, REM sleep behavior disorder, right? Now, see, some things that have been frequently asked in the exam is REM, NREM, nightmares versus night terrors, sleep stages. Okay, so very, very quick, we'll do a revision. What is REM? Rapid eye movement, where the most vivid dreams occur. Brain activity is high, okay? Then we have NREM, okay, non-rapid eye movement stage. There are 3 stages, N1, N2, N3. Deepest stage is N3, also known as slow wave sleep or deep sleep, okay? N1, lightest sleep, okay? This is like the transition from being awake to being asleep. N2 is the majority of the night, okay? You will see sleep spindles here, K complexes here. Favorite question in exams, comes in approximately like every alternate exams, if I have to say. N3, most deep, most slow wave. You will see sleepwalking here, night terrors here. And then comes REM sleep, where dreams occur, muscle tone is absent. What is the difference between nightmares and night terrors? Nightmares occur during REM sleep, okay? The person will wake up completely, okay? They'll remember the dream in detail, okay? While night terrors, they occur in that N3 deep sleep, okay? The person will suddenly scream, sit up, appear terrified, but they're not actually awake, or they have very little to no memory of that episode the next morning, okay? So that is the difference. Now let's move on to sexual disorders. There are 4 sexual disorders that have been mentioned here. Before looking into that, what is sexual dysfunction? Okay, sexual dysfunction is any kind of difficulty during normal sexual response cycle, which is causing you significant distress. So, in other words, the person wants to engage in sexual activities, but there is some kind of problem, whether it will be with desire, will be with arousal, will be with orgasm, or some kind of pain. So first, let's look into erectile disorder. Here, the individual is having persistent difficulty in achieving or maintaining an erection, which is sufficient enough for satisfactory sexual activity. Only when it is persistent, it is recognized as a disorder. Okay. Then we have female sexual interest or arousal disorder. DSM-5 combined the older diagnosis of hypoactive sexual desire disorder and female sexual arousal disorder into one diagnosis. So here, patients may report reduced sexual interest, fear sexual thoughts or fantasies, reduced initiation of sexual activities, basically reduced sexual excitement. Okay. Then the third is genitopelvic pain or penetration disorder. Again, this diagnosis also represents a DSM-5 update. The earlier editions had 2 separate diagnoses, like dyspareunia and vaginismus. Okay, they have been merged into a single disorder. So what happens here is the patients experience some kind of pain during penetration, or there is a fear of pain, there is tightening of pelvic muscle floors, or there is just marked anxiety related to penetration. Then we have premature or early ejaculation. It is characterized by ejaculation occurring much sooner than what was actually desired, with just minimal sexual stimulation. Okay, and it leads to some kind of distress in the couple or the individual. Now, the first term that I need you to look into is sexual dysfunction. Okay, here the problem is with the sexual response itself, the desire, the arousal, the orgasm, or the pain. But in the paraphilic disorder, we are saying atypical sexual interest. It's not about sexual functioning. Instead, it involves atypical sexual interests or urges, which is causing some kind of distress or impairment, or it can even involve non-consenting individuals. So the issue is with the nature of the sexual interest, not the person's ability to respond sexually. Then we have gender dysphoria. Gender dysphoria has nothing to do with sexual functioning or sexual interest. It refers to some kind of clinically significant distress arising from an incongruence between a person's experienced gender and the sex that has been assigned at the birth. Okay, what you need to understand is the problem is the distress is due to the gender identity. Okay, remember that the gender identity is the problem. There is incongruence between what they have been assigned at birth and what they experience. That is the difference here. That is all about sexual dysfunctions as well. Remember the DSM updates again, here as well as here. Okay, now let's very, very quickly look into some of the important scales. I would tell you to take a screenshot of it to remember it. Okay, for dissociative disorders, we have DES, Dissociative Experiences Scale, to screen for dissociative disorders or dissociative symptoms. Screening tool. There's again a screening tool. Okay. Then for somatic symptoms, we have PHQ-15. Okay, it measures the common physical or somatic symptoms. Okay. Then we have Whitley Index for Illness Anxiety. As the name is suggesting, it measures, it's an index, so it measures excessive health concerns or illness related beliefs. Then for eating disorders, we have EDQ, EDEQ. We have already discussed this briefly. It is again a self-report questionnaire related to eating disorder psychopathology, concerns about eating, body shape, body weight, things like that. For alcohol use, we have audit. One of the most widely used screening tools for identifying hazardous, harmful alcohol use, common use in hospitals, primary cares, community settings, everywhere. Then finally, we have DAST. This is associated with drug or substance use, excluding alcohol, not for alcohol. Not for alcohol. Okay, it screens for problematic drug use. It is frequently paired with audit, actually, in clinical practices. So take a screenshot of it to remember the name of the scales, and just remember these two are used together a lot of times. With this, we are done with half of our module 3. We will continue the rest in the next session. Okay, let's test what you have learned. Again, the system is same. Pause your video, answer the question, then see if you answered it correctly. In dissociative amnesia, which type involves forgetting one's entire identity and life history? Which involves A, localized amnesia, B, selective amnesia, C, generalized amnesia, D, continuous amnesia. Remember, forgetting one's entire identity and life history. The answer would be C, generalized amnesia. Okay. Second is, what differentiates factitious disorder imposed on other from factitious disorder imposed on self? A, the symptoms are fabricated by the individual for personal financial gain. B, the individual induces or fabricates symptoms in another person only to gain attention as a caregiver. C, the disorder is characterized by complete avoidance of medical care. And D, it involves malingering where the incentives are evident. What would be the answer? The answer would be B, the individual induces or fabricates symptoms in another person only to gain attention as a caregiver. Okay. So, remember, this is talking about imposed on other, imposed on self. The point of factitious disorder was care, or attention, right? So, that is what this person is getting here. Next question. What is a common co-occurring condition found in individuals with anorexia nervosa? A, obsessive compulsive disorder. B, B, panic disorder. C, borderline personality disorder. And D, schizophrenia. Which is a common co-occurring condition? Remember, the question is co-occurring. So the answer would be obsessive compulsive disorder. Obsessive compulsive disorder. Fourth, which of the following is not a characteristic feature of insomnia disorder? A, difficulty initiating sleep. B, difficulty maintaining sleep. C, daytime sleep attacks. D, early morning awakening. The answer is C, daytime sleep attacks. We have already said difficulty initiating, maintaining, and early morning awakening and difficulty falling back to sleep are characteristics of insomnia disorder. Daytime sleep attacks is more related to narcolepsy. Okay. Then, fifth is, a 43-year-old man with a history of consuming approximately 180 ml of whiskey daily for the last 5 years abruptly stops drinking alcohol. I'm pretty sure it stops. Okay. 2 days after cessation, he becomes confused, disoriented, surroundings, and reports seeing small insects crawling on him, appearing terrified. What is the most likely diagnosis? A, alcoholic hallucinosis. B, schizophrenia. C, delirium tremens. And D, dementia. The answer is C, delirium tremens, DT. We already said this is one of the major symptoms where there is agitation, hallucination. There's nothing like alcoholic hallucinosis. This is what is happening. Okay. With this, we are done with half of our module 3. Go and attempt the mock test. Okay. Try to solve everything by your own. It's okay if you're not able to solve everything. Come back, revise, and I will see you for the next session where we will complete our module 3. Till then, bye-bye. Take care.